All right. Okay, everybody, welcome again to our exam two review. And it's going to be covering chapters 6, 7, 8, and 9. A lot of chapters, everybody. All right.
Mhm.
So I got a little cartoon here, and this is all what we've been studying about, little complications of pregnancy. And I thought now looking at her, you would think, oh my goodness, look all these complications. And they're all the things that you've been studying anyway. So I'm going to jump over here to culture. Now, yes, culture does have influences on the birth. And just like, I had a patient that she was American Indian, and she wanted to have all her family and her tribe.
Hmm.
And so I recognize that, this is part of her culture. So write this down. Nurses have to be sensitive to the patient's culture. We're sensitive. So what I did for her was I allowed everybody in the room in the LDR, and then they had a ritual, and they went around the bed, and they did their ritual. Now I'm going to tell you, my patient did absolutely fabulous during her labor and delivery. Fabulous. Because
Huh.
why? Why do you think she did so good?
The support, her whole family was there supporting her.
Exactly. Her whole family was supporting her. She knew that I was on her page per
Yeah.
se. I was in her ball game. I was backing her up. I was believing in her. And she and I had became, and nurses do that. We have a good relationship with our patients. And when they see that we're respecting them, they respect us.
Uh-huh.
Oh, so I want you to make sure that you see this, that the nurse needs to be sensitive to the specific needs of the patient. It doesn't matter if it's maternity patient, medical surgical patient, is an ER patient, no matter what patient, where the patient is, we have to be sensitive. And our role is to be active and a good therapeutic what? Listener. So we demonstrate cultural sensitivity. Now, I know there's one little question on that test that has about that. So that's why I'm going over this about culture and that what we are practicing cultural sensitivity. Okay. So it doesn't matter. We're going to provide the care under any circumstances of the mother and infant and the nurse caring for the childbearing family. We have a responsibility, again, culturally sensitive. Every group of individuals, if they're adolescent, they're single mom, doesn't matter. We take care of them, right? Okay, let's go on here. All right. So when we have these different cultures and we have different languages, right? And so sometimes we don't communicate with our patients as well as we should because we don't know their language. I mean, I don't speak 6 different languages, but I was able to take care of any type of patient or any language is because why? I use an interpreter. You have to use an interpreter when appropriate. So you imagine we had to get creative in labor and delivery because I could have a patient that come in and she could be crowning. And so the thing is, and she may not be able to speak English, but I tell you what, when it comes to pushing or delivering a baby, I think we speak all the same language. But remember, you use an interpreter. Okay, so let me give you my little brain teaser. And my brain teaser is a question. So, which of the following nursing actions describe culture insensitivity in the care of the laboring woman? So, see how we change that to culture insensitivity. So, which one of these would be insensitive to the patient or the mom?
B. I think
B.
B, B, absolutely. B as in boy. Yes, because that's very sensitive to that Muslim patient, and we want to always be respectful. Yes, good. Okay, you got it. Okay, okay. So let's go on now and discuss about the birth process. Okay, so here's your 5 P's. Some of the books go for 4 Ps, but L&D nurses, we put the fourth one in position here, just letting you know. Okay, so here's the powers or the components of the birth process, and the big one is the power. A power is uterine contractions. And so you have to have the uterine contractions to what? To dilate and efface the cervix. And the uterine contraction has a cycle. And so we call these frequency. How often are the contractions coming? Duration. How long is the one contraction lasting? You hear me? One contraction lasting. And then the intensity. Intensity is you palpate using how many fingers? Two fingers. And you see my little fingers? And basically what we're doing is we're just going to put our fingers on the fundus of the uterus, which is the top portion of the uterus, and we're going to assess how strong that is. Okay, so if you're in my class, you know this already, but I think we have a visitor here, so I'm going to go over it. So if you have a mild contraction, what is it? Is the tip of your nose. So touch your nose. That's a mild contraction. If you have a moderate contraction, touch your chin. That's moderate. Okay. And a real firm contraction is the forehead. So touch your forehead, and that's firm. Because now you can see why during that transition, when their contractions are really, really firm, they're in pain. Okay, well, they have pain. And we have to have good contractions. So we have to have for frequency, every 2 to 3 minutes. For duration, we want 60 to 90 seconds in duration. And intensity, you have mild, moderate, and firm. That's your contraction. Very, very important. Now, passageway, how we're coming down. Remember, the gynecoid pelvis is the most favorable for vaginal delivery. The passenger is the baby, is the fetus. Now, position, you could be, baby could be in OA position, OP, and OT. The most favorable for a vaginal delivery is OA. That's the occipital anterior, where his little head is tucked down into his chin, into his chin, so he's all tucked down and ready to descend. Now you can deliver OP, which is occipital posterior, but that's harder. That's a harder labor. Write that down. It's a harder labor, and the labor will last longer. Okay, that's OP, occipital posterior. Now OT, that's where the head is like transverse. It's like his top of his head is horizontal to mom's pelvis, and now that we have to switch. We have to get her to switch from OT to OA, and we do that by different positions of mom. We get mom up, we get her on her side, we get her squatting on a ball, we get her in hydrotherapy. We do whatever we need to do, and all fours is really good, guys, for changing from an OP position to an OA. And then the last P in the labor birth process is psych. And patient needs support. And I tell you, I've seen it over and over the last many years of working in there, is that they need a lot of support, because to get this baby out, it's a lot of work. It really is. Okay. Now, we're going to go over a couple things here on the reproductive system. Our uterus. Okay, so the uterus, it involutes or reduces in size of the uterus. This is after delivery. The uterine lining is the decision web, which is shed when the placenta is expelled, and the descent of the uterine fundus, that's involution, 1 centimeter, 1 to 2 centimeters each day. That's your after pain. Now, lochia, let's see here. The lochia is your drainage. Okay, so rubra is red, serosa is pinkish, that has blood and mucus, and alba is white. So this is like after delivery. So we kind of jumped, I see, from being in the labor room into the postpartum period. And then you had your cervix. Now your cervix had to dilate, right? So it never really goes back down to normal. It'll be soft, but it closes back up. And then you have the vagina, and then you have the breasts. And we'll talk about the engorgement and breast care. Okay. All right. So we're skipping right into the episiotomy, and that's your surgical cut in the perineum to deliver this beautiful baby. So we have our assessment, and if you don't know this, I would write it down. It's called REDA, and so that stands for redness, edema, ecchymosis, and approximation. So we know redness is red, edema is swelling, ecchymosis is bruising, and approximation is when they do a episiotomy, it's a surgical cut, right? So they're going to sew her back up. And so one side, if you see my hands, one side is approximated to the next other side, and then we sew them up. Okay. Now write this down because this is really important, that after your care during postpartum for the episiotomy is you're going to apply a cold pack. Yeah, ice on her bottom. Please, after you have an episiotomy, is your best
After episiotomy, put a cold pack.
Hi, Mr. Brown. So you want to have your episiotomy, nice cold pack on your episiotomy. And then again, don't forget, everything starts all over again, and you have the return of ovulation administration. Okay, let's see, we got a brain teaser here. All right. So which nursing intervention should the nurse include for a client immediately after delivery to reduce bleeding and bruising of the perineum? Which one?
A D.
D as in dog?
D.
D as in dog.
D as in dog or document. Yeah, that's it, right. So that's a good question, don't you think? I think so. All right. Yeah. Okay. All right. So it seems like my other couple little slides were out of whack here. I'll have to fix that. So anyway, let's go back to contractions. You poor things. We're back into labor. Yeah, I apologize. Those 3 slides kind of got pushed out of the sequence. But anyway, the information is still the same. Here's your effect of your contraction. So remember we were talking about contractions before? Okay, remember, true labor is effacement and dilation of the cervix. Write that down, just like I said. True labor, when you know somebody's in true labor, you have dilation and effacement of the cervix. You have a phase of contraction. Now, you know the phases, right? Increment, that means it's going up, right? The peak is the top of the contraction, and then you have what? Going down, which is your decrement. Okay, now, I highlighted this for a reason. So look at it, look at the definitions. We just went over that before. Just the frequency, the time from the beginning of one contraction to the beginning of the next contraction. Okay. When you say to your patient, how often are your contractions coming? You are talking about the frequency. So she's going to tell you like every 2 to 3 minutes apart. All right. Now, when you talk about how long they are lasting, that's duration. And that's the interval, the time from the beginning of the one contraction all the way to the end of that one contraction. Does everybody hear? I said one contraction, correct?
Correct.
Okay, good. Because that's where a lot of students get mixed up, is the frequency and duration. And so be sure to read that very carefully. And then I already talked about intensity. Yeah. Yeah, that was kind of funny how my slides did his own thing here. All right. And let me move on. Let me get my next slide. Anybody have any questions? Okay, so here's my, I love this contraction cycle. It shows you exactly what I've been saying. So increment. Now tell me what type of breathing is she doing during the increment where the contraction is what? Going up. What kind of breathing?
Rapid.
Not rapid, not rapid yet. What if I'm just starting out?
Maybe shallow and deep breathing.
Yeah, yeah, slow, right? Slow, deep breathe, like in and out,
Yeah.
in and out, right? Now, contraction, the power is going up. So I'm at the peak, or this is another term that means peak. And I tell you, giving you a hint, Hesse likes to use that term, acme. Same thing, ACME. It's an old term. Okay, so this is where it's really intense. Your forehead you just touched before is pretty firm. Okay, so it's causing her a lot of pain. So what kind of breathing do you think she's going to do here? Remember that alternative breathing, that kind of a rhythmic? Listen to what my breathing sounds like. I'm going to do it for you. Goes like this. It's called he blow. He blow. And when it gets really, really tough, you can increase it, go he blow, he blow, he blow. And she does that. Now, I don't want her to do it all the way down. As soon as this contraction starts to go down, I want her to go back to her slower breathing. Because if she keeps up that rhythmic, that really rapid type of breathing, she can hyperventilate. And I don't want her to hyperventilate. Okay. And if you hyperventilate, what can you do? How can you correct the hyperventilation?
Let her breathe in her palms or something, or in a bag, paper bag, or a wet cloth.
Yeah, like a paper bag. Now, if she doesn't have that in her little kit, then she can take her hands and see my hands. I'm going to cup over my nose and mouth. See what I'm doing? And then tell her to breathe normal. And that will help. Okay, so that you can use on any patient who's hyperventilating. Okay, so I'm coming down the contraction. So this is called the decrepitment. Now I come down to here, and this is where I want her to rest. See here, relaxation time. And then it goes back up. Okay, so here we go. So here, let me go back here. So we talked about frequency. So if we're talking, let me show you. So we started this contraction, and we're going to count the seconds to the beginning of the next contraction. That's frequency. Okay. Duration is this blue right here. This is the time from the beginning of this contraction, one single contraction, to the end of this one single contraction. That's called duration. Okay. Does everybody have that down packed? Okay. Now, since we're here, and we can talk about a little bit about maybe pain management here. So if your patient is in pain, okay, and so now she's having contractions, and they're pretty rhythmic, like we see here, and they're lasting at least 60 to 90 seconds in duration. And she's just saying to you, oh my goodness, nurse, I need maybe an epidural. A good time for an epidural would be when she's having these kind of contractions, plus she's like in the active phase of the first stage of labor. So that would be when maybe she is like 5 centimeters, active phase begins at what? 4 centimeters, goes from 4 centimeters to 7. So that would be a good time to get this girl to have an epidural. Now, your other patient may say, I don't want an epidural, nurse. Okay, that's all right. What would you like? And she's really having a tough time. She's not relaxing during her relaxation period right here. So you might give her maybe some Stadol, which is narcotic. Now, let me tell you, Stadol does not take away the pain of this contraction. What Stadol does is during the relaxation period, right in here, that makes it more tolerable for her, and she can rest. And then her contraction starts again, goes up. She breathes during the contraction and she comes down. And then she comes back to her resting zone here and she rests. So that's what pain medicine does for the pain during labor. So it's always very up to the patient and whatever she wants. Alrighty, I have a little brain teaser. So I want you to write down what is the definition of duration. And I want you to be, after this over, I want you to be able to write it out. What's the definition of frequency? And then how does the nurse assess the intensity of the contraction? Okay, those are just important that you know that. Alrighty. Now Braxton Hicks. Now you might see this one again. So Braxton Hicks are irregular contractions. Now they do begin like in early pregnancy and they intensify as the woman gets closer to full term. And Braxton Hicks are just what they are. They're irregular contractions and they don't dilate the cervix. Now, there is some research that says that maybe they would efface the cervix, but Braxton Hicks usually are very they are annoying contractions. So I want you to write this down, that Braxton Hicks are irregular contractions. Okay. So if I was to ask you a question, let me see here, that which assessment finding does the nurse recognize as Braxton Hicks contractions? And what would you put down?
Irregular contractions.
Irregular contractions. That's right. You got it. Okay, let's move on here. My little arrow. All righty. The next one, oops, that's not what I wanted. Let's see here. I'm down here. Okay, here we go. So I just wanted to show you again cervical effacement dilation. That is a sign of true labor. Now, a great question could be true labor. How do you know the person is in true labor? And you want to go over cervical effacement dilation. She's got to be what? She's got to be effacing and dilating. That's what it comes down to, that she is dilating and she is having regular rhythmic contractions. Okay, so if you see like a question about fetal lie, all it means is that is how this baby is lying inside of mom, according to her what? Her spine. So this baby is in a longitudinal lie. So you can see here, so mom's spine would be coming right down the middle, right? And so the baby is lined up with her spine. This baby here, oh yeah, he looks like he's sucking his thumb and everything in here. He is in a transverse lie. And so he's just happy-go-lucky. And mom, though, will end up with a C-section on that one. Because you can't deliver a transverse lie. There's no way. So you can see how
Question.
Yeah, go ahead.
It can do like the Balsavic maneuver and turn the baby around or something?
Well, you can, but it's hard with a transverse lie, and it's hard when they're a term baby. Now, when they're before term, if they're in a transverse lie, they could try to do something, or they could do a version. But, you know, this is pretty hard to turn. I'm going to be honest with you. The easiest babies to turn is when they're a breech lie, breech presentation. And so that means that their buttocks is down here and their head's up here, and you want to turn them. And we can turn them using ultrasound guidance and put them into a vertex presentation. All righty. So here's your different presentations. And so here, your babies, this is complete flexion. Now, they're not going to have to really, go into this too much, but just know that these are different presentations, and that if your patient comes in and she's in a breech presentation, what type of delivery will we be doing?
C-section.
C-section, right. Because you're in the United States, we're going to have a C-section. Exactly. Okay. All right. And you can see the different breeches. So I call this Mr. Frank breech. And how I learned it years ago is that I called him Mr., is that he loves to expose everything. I got my feet all the way up to my head. I'm just Mr. Frank. Okay. And here's your full breech where the baby's head is up on the upper portion and the buttocks is the what's presenting itself. That's a full breech. So you can see the difference. And then here's your footling breech. Now, when you go in, you do a vag exam, sterile vag exam, you will feel a foot. Okay. On this one, on the shoulder presentation, I one time did my vag exam as a brand new nurse in labor delivery, and I had a baby actually grab onto my fingers, and when I was in, and that's a true story. And I went, woo, okay, and I said, we are in a shoulder, or we have an arm coming through, and sure enough, he was, and we had to do an emergency C-section on that baby. And the baby came out just fine, a little bruised, but fine. And meanwhile, I never forgot that experience in my whole entire life. Okay. So here you go. You got some different fetal presentation position. What I want you to get out of this is the occipital anterior. And you can see the baby's nicely tucked down. And that's a really good position to have a vaginal delivery. Okay. And what we're looking at here is, here's mom's pelvis, here's the posterior, and here's her interior. So when we talk about occipital anterior, that means the back of the baby's head is facing mom's front. See? So that's a nice position. And then when you say left, it's just that's how the baby has his back, is to mom's left. And this one here, OP. Now, OP is occipital posterior. So the back of baby's head is to mom's posterior. Now write this down. OP gives mom a tough labor, a longer labor, also more pain. So they usually are OP, say in the beginning of labor. Okay. And then as we progress, as she dilates and he faces the cervix, the contractions, it starts to move the baby around and it goes into OA. But in the very beginning, and she's an OP, that's painful. You can see that would be painful, correct? So what we're going to do is have her up, maybe have her lean over a bedside table. That was the best stretch. Actually, you put a pillow on the bedside table, and then the patient stretches across that pillow. And now her back is, oh my gosh, it gives them such relief. And then you take your hand, see my hand, the palm of my hand, and I press it right against her sacrum. That's that sacral pressure. Relieves back pain very nicely. Now let me, while I'm here and talk about OP, they can deliver OP. They can. It just they push harder. That pushing is what? The second stage, right, of labor. So they push harder. So maybe it's going to last longer than 2 hours. Now you got to be careful because your patient can get very tired during that time. So you want to have her focus, do the best she can, and push this baby out. Okay. So this is just the different positions that you're seeing and what's presenting. Okay. Now here, not to forget about Mr. Transverse, you can see how his head here is in the pelvis, how is more of a horizontal than anything. Hopefully we can go up and turn him a little bit so that he can flip into an OA. A lot of times you flip them into an OA position and they go right back to transverse. This is a little harder because, we use the baby's head presses against the cervix to make that cervix even dilate some more too, especially when the bag of water is broken. So this here would make her to have labor dystocia. And she probably would end up, if we couldn't get it to turn and stay turned, it would end up what? She ended up with a C-section. Okay. We try our best to get them to be the right position. Psychic, I'm very much telling you, mental state can influence the course of labor. Patients that are more relaxed have support. They open up a lot easier and work with their support people. Now, write this down. Doula, DOULA, is a support person, and she's there strictly to give emotional support to the patient. Okay, and they're very good, especially if you don't have somebody with you. Okay, now normally L&D nurses, that's our job too, is to provide support for the patient. But say we have 2 patients, right? We can't be in the room all the time with her. The doula is contracted with the patient, and so because patient hires a doula, and so they're in there the whole time with them. Okay. All right. Let me tell you, let's go over some signs of impending labor. All right. So even though Brassicus contractions are irregular and they can be a pain, I always tell my patient that, you know what? That's a good sign. Your body is trying to rib up, get ready for the good contractions. Sometimes it makes the patient come into triage, labor and delivery triage, a little bit too often, but that's okay. Impending labor. She might have some increased vaginal discharge. So she can see that happening. And I get this, you could have some bloody show. And I highlighted that. That's for a reason. So bloody show is like the mucus plug. So it's real mucousy, and it gets dislodged from the cervix, and it has blood in it. Okay. She's not hemorrhaging or anything, but she is bleeding a little bit. Now the cervix is a very vascular area. And so, yes, it will slough off blood when it's opening up. So when I see my patient having bloody show come down her leg, I go, yes, that means we're dilating, okay, the cervix. And that's a good sign. Now, another sign of impending labor is that she is at home and she has spontaneous rupture membranes. Woo! Yeah. She's gonna go into she's gonna start her own contractions, which is made by what? Oxytocin from the pituitary, or she's gonna have to be augmented with Pitocin. All right, so rupture membranes. And while we're here on rupture membranes, I want you, when you see a patient and she has rupture membranes, what do you have to look at? The color, right? The color of the amniotic fluid. What color is normal amniotic fluid? What color normally?
Clear?
Yellowish clear.
Clear. Yeah, clear. Does it have an odor?
No.
No. If it has an odor, what is that indicative of? What does that mean?
Infection?
Infection. Good. And so I want to make sure that and what else am I concerned about? And say your patient is at home. What am I concerned about? What do I tell my patient to note when she ruptures? The time. Write down the time that you rupture, because I tell you why. We only have 24 hours from the time of rupture to the delivery of the fetus, the baby. So otherwise, when you go past that 24 hours, then you get into an area of infection. And so we don't want that. No. So we time it. Also, too, when you have rupture membranes, you have to make sure that she doesn't have any kind of prolapsed cord, because the head could be up high and therefore that cord could prolapse. So there's some things, but again, getting back, is a sign of impending labor. And how about an energy spurt? Yeah. Now I tell you what, people that are starting to go into labor, they like to clean the house. They'll mop. They'll be doing the laundry. They get this spurt of energy. Now, another thing of impending labor is that they kind of pull back on their eating. I don't really see this too often, this weight loss, but it can happen. All right, so here I want to go over a little bit of birth station and station. So when you hear maybe your patient is, say, 6 centimeters, Okay. And she's completely effaced, and the baby's head is at a 0 station. That means that the head is right here. See here? This is at the level at the ischial spine. So these ischial spines, when you go and check a woman, those ischial spines are pretty prominent. You know, you can feel them. And so that's how we gauge. So this baby's at a 0 station. So he's now coming down in the pelvis and he's engaged, which this is good when they're at a 0 station, is because this head will put a lot of pressure on that cervix. And so, so that's a good thing. That's a good. So she's 6. That means what? She is in the what phase of the first stage of labor? She's 6 centimeters.
Second stage.
No, not second stage. She's in the what phase, I should say. What phase of the first stage of labor is if she's 6 centimeters?
Let's see,
Third phase?
Latin.
Huh?
Active.
No. Active. Okay, so now active. So get your pen and paper and write down first stage of labor. Then under that, you're going to have the first phase of the first stage of labor, and that is the latent, or some books call it the early. Okay, that's where she's dilated maybe from the beginning, say 1 centimeter to 3, or some books say 0 to 3. Okay, the next phase is called the active phase, and that's where she's dilated from 4 to 7 centimeters. The next phase is called the transition phase, and that's where she's dilated from 8 to 10. Okay, so those are your different phases of the first stage. Then from there, you'll go into the second stage when she is completely dilated and she's going to push. Okay, that is your second stage. Your third stage is the delivery of the placenta. And then the fourth stage is your postpartum recovery. Usually recovery, sometimes you'll see it recovery 1 to 2 hours after birth. So that is the fourth stage. All right. So when you write it that way, you can see it better. Okay. All right. So if I was to ask you, your patient is, let's see, 8 centimeters. The baby's head, she's completely effaced, and the baby's head at a +2 station. What phase of the first stage of labor is she in?
Third phase.
Third.
Transitional.
Transitional phase.
That's
Oh,
what
so we talk about the transition, the active and the latent. We don't talk about the phase. Okay.
that's the phases. So you got your first stage, your second stage, your third stage, and your fourth stage.
Oh,
Your first stage has the 3 phases.
okay.
Okay, phases, that's PHASES. And
Mhm.
that's where you have the latent phase, the active phase, and the transition phase. Okay. All right, everybody got that? Pretty good
So
now?
it's also say
Latent is like first, right?
third phase.
Pardon? I'm hearing 2 questions. Go ahead, one at a time.
Can you also say the transition phase is the third phase?
No, that's where you're coming in. That's where you're coming in. The transition phase is the phase of the first, is part of the first stage of labor, but it's a phase of the first stage of labor.
Uh,
So you're saying it wrong. You're saying that you're putting that in as a stage, but it's a phase. It's not, is part, listen up, is part of the first stage of labor.
okay.
Okay, now,
Professor,
yes, you go ahead.
hey, with the first stage of labor, including the 3 phases to
Yeah.
help her understand. Could you say like it's like with the dilations, because that's how I can remember it. It's based on like the 3 different levels of the dilation, you
Right.
know? Like, so
Mhm.
maybe she won't get it so confused if you say, you know, in the first stage, you have the 3 phases of like the dilation, and like the active phase is the centimeters is like 4 to 7, and that's when
Mhm.
you can like give the epidural and like things like
Right.
that, to, you know,
Right.
so she won't get confused.
No, you explained it very well. And we went over that. So that's good. You were listening. Thank you. Yes, good. You got it.
Yes, ma'am.
You got it. And sometimes that's why I said it over and over again. And that's why I asked you, is because from the past, I know students get that mixed up because you're thinking only stages, but there is part of that first stage is the 3 phases, where it's broken down by dilation. So in the beginning, she's dilated maybe from 0 to say 3 centimeters. So she comes in and she's like, "Hi, Tia, how you doing? My name is Mrs. Jones, and I'm here to have a baby." She's real, like real friendly, you know. And oh, this is the pretty room. Okay, she's only in the beginning. Then now she's going to be, oh, these contractions, they're really tough. So then Tia will go ahead and check her, and Tia found that she is now 5 centimeters. So she has now entered into the active phase of that first stage of labor. So she's more active. So then she would either say to Tia, "Well, yeah, I have my epidural now." And that's usually when we give an epidural. And then she's able to handle it. Okay. If she wants just narcotics, we can give a narcotic during that time, is because it's plenty of time before she delivers. Now, then she tells Nurse Tia, "Oh, I had to push." Okay. And so she gives out this like big bloody scream, and you go, "Okay, I'll check you." And Nurse Tia finds out that now she's what? Completely dilated. So she jumped into the transition phase of the first stage of labor. So now Tia explains to her how to push, and now she's in the second stage of labor. Does that help?
Yeah.
The first
Okay.
stage of labor, did you also call that latent? The latent?
I call the first, okay, so this first stage of labor, that first one is latent or early phase, and she's like it goes from 1 to 3 centimeters. She's in the early or latent phase of the first stage of labor. Okay, the old term is latent, latent, and then you might see some books referred to as early phase. That's why I said it that way. Everybody got it now?
Yes.
Yeah, you got it? Okay. So you see the difference. So now you can understand when you're looking at a question, I want you to read the question, and it might say Mrs. Jones is in the first stage of labor, and she is experiencing contractions every 2 to 3 minutes. Her dilation is 3, say, let me go, say 6 centimeters. She's 6 centimeters completely effaced, and the head's at a 0 station. What phase is she in?
Active.
Active, right? You got it. Okay, so that's how those questions are worded. So you have to read them carefully and not jump to a conclusion. You have to figure it out, that okay, exactly where she is, and you got it. Okay, I just want to give you that warning. All right. Okay. All right, here's your comparison of false and true labor. I kind of went over this already, but here it is. So you have false labor. This is when you have irregular contractions, and another term for irregular contractions is called what?
Braxton
Braxton.
Hicks.
Braxton Hicks. Good. Okay. Then you send this patient out walking. Okay. And she comes back and you, the nurse, say, well, how did you do? And she says, oh, my contractions are like now every sort of 8 minutes, some are 6, some are 10. So what happens is the walking kind of relieved the contraction. They kind of went away. Okay.
Oh, yeah.
So that's false labor.
Okay.
Then you don't have any bloody show with false labor because the cervix is not dilating and there's no change in effacement of the cervix nor dilation. So that's when when you get it, when you're working in the triage area and you're seeing these patients, this is what you're looking for. Now, my other patient that comes in and her contractions.
Yeah, Daddy understood that way yesterday. He don't want you to be doing it.
Okay, go ahead and mute
I
yourself.
need to tell Miss Jimmy not to
Winnie.
buy that.
Winnie. Put yourself on mute.
That's not day.
Okay, make sure you're on mute. Okay, now true labor. Your contractions are a regular pattern. So remember I said the best pattern is like 2 to 3 minutes apart, 60 to 90 seconds in duration. They have a regular pattern. So my patient, so I say, well, I'm going to send you out walking. Let's see what happens to the contractions when I send you out walking. And so she's walking and they become stronger. And now they're, they're really very effective. She's like coming back and saying, nurse, I think I'm in labor. I said, good. They got stronger as you walked. And she said, yes, wonderful. That's what I want. And her back hurts her. Okay, remember I talked about that baby being an OP position, giving mom a back labor? That's where it is. And bloody show. Remember I said that bloody show, I love it when I see bloody show. It's because now I know the cervix is opening up. The cervix, don't forget, is a very vascular area, has a lot of blood supply. And so when it starts to open up, it can slough off some, blood. Okay, it comes out. It comes out like real mucousy type. And that's bloody show. Always good. And then, of course, I'm going to check her. And so she went from maybe on admission, she was 3 centimeters. Maybe she was 50% efface. Well, guess now, an hour later, she's now 5 centimeters completely effaced. Those contractions are very effective. So what do I do with her? I'm going to admit her. Mrs. Jones, we're going to admit you to now labor room number 5. And so then we take her to number 5 and tell the nurse that she has a new admission. Okay, so that's the difference between false labor and true labor. Now, a good question would be that they would describe, maybe true labor, and you have to cipher out, is that true labor or false labor? Or, so you have to just read carefully. And I always tell my students, always read always ask, what's the question asking me? All right, so here, how about a little question? A laboring woman is uncomfortable and her labor has slowed down. Oh boy, huh? So which instruction should the nurse give to the client to help stimulate labor?
D.
D.
D, absolutely. Get her up and get her to walk because that will stimulate labor. All righty, so good. So here's a picture of typical fetal monitor. And you can see here that this is right here, this is the fetal heart rate. And you can see where, has a good baseline, maybe about, I can't say that, I just say baseline of 120 with good acceleration. That's good. So over here, excuse me, this is the contraction. So you can see she's had one contraction there. It looks like she's starting a little one over here, but you may have to reposition that toco a little bit to pick up the contractions. So over here is the fetal heart rate. So it's 113. And then contraction is 22. And normal resting tone in between contractions, usually around 20. So that's okay. This is her blood pressure. So you got the blood pressure, automatic blood pressure cuff on her, and it's reading 135/70. And then this is her pulse. So she's working pretty hard because the pulse is up, right? Okay. So this is called continuous electronic fetal monitoring, which is a really good tool that we use in labor and delivery. And here's another printout. So here, this one shows baby's heart rate at 148. It's just a different, version, different model. That's all it is. But it's right there. You can see here the top monitor is called a tocodiameter, which we shorten that down to call TOCO, TOCO, and that picks up the contractions. Now, where I put this TOCO is on the fundus of the uterus. The fundus, remember, is the top portion of the uterus. That's where my powers, the contractions start. Now, this monitor down here is the ultrasound. It's called the ultrasound transducer, and that's to pick up the fetal heart tones. Okay, so I'm always monitoring my patient in labor and delivery in the labor room. So you can see she's not too happy, is she? So she could be now, she's breathing with the contractions, not too happy. I'm going to go ahead and turn her more on her side. She's got a pillow. The nurse is putting a pillow behind her back. She's having probably back labor. So she's probably about, what about maybe 3 centimeters? And she just needs a little encouragement. Okay. So that's what we do. Here's another one. Here you can see the fetal heart rate, 148. Again, just a different monitor. The uterine contraction, this is showing 26. So that means it's starting to go up. And that's what the tool, when you see those numbers on the TOCO going up, that's when you can, I always taught the daddies or the significant other in the room, when you start seeing that number going up, start coaching her to start her breathing. Okay, so start your breathing because you can see the numbers going up. And this one here is a really good monitor. This has the capability of monitoring twins. So you would have another plug here and you could monitor twins at the same time. What you do is you get 2 different printouts, and one is a little lighter than the other. So then I would always just mark twin A or twin B so I could keep track of them. All right. Let's go on. So let's talk about your favorite thing is fetal heart rate. Okay. So what you have to know is 110 to 160 is your normal fetal heart rate, correct? Yes. Okay. Now anything below 110 would be considered bradycardia. Okay. So I would just put down 110 to 160 normal, and then less than 110 would be bradycardia. And then anything greater than 160 would be considered tachycardia. So, and tachycardia, you have a baby that a mom comes in and she's got a fever, that will cause fetal tachycardia because now mom has a fever, her body temperature has gone up, it affects the baby's heart rate. He'll go up. Maybe mom just had a drug. And so that crosses, drugs cross the placenta. And so that could make his heart rate go down. Okay. So you need to know probably how to recognize these. And then you have variability. Now, all you have to remember about variability is like those little squiggly lines, I call them, they're up and down. They're undulating up and down, up and down, up and down. Those are variability. When you have variability, you have a well baby. It's just the same as an adult EKG. When you see that you have the QRS complex and the ST and all that, you have a normal EKG. Your patient is okay. All right. When you have less, then the patient starts to lose a little bit of that. Then you start getting into maybe more of a absent variability, which is never good. Absent means straight, could be almost going to a straight line, which and straight lines in anybody is never good. Okay. Marked variability is you got a bunch of those squiggly lines and they're really up and down, up and down, up and down. And that tells me that baby could be compromised in some way. And I had to maybe turn mom to her side, maybe get the IV, get some fluids in her and to control that. Okay. So that's how you can remember that. Here, I know everybody's gone over veal chop, so I'll just kind of briefly go through it. By veal chop, you have variables. Now, variables are just what they sound like. They vary. Some are V, some are W's, but they vary. And there's no set pattern to them. And what causes variables? Baby is holding on to what? His cord. He grabs his cord. And when he grabs his cord, his heart rate goes down. But then I release my cord. And so it goes back up real quick. So I grab onto it. It's cord compression. My heart rate goes down. I let it up because my next, they grab and then they let up. And my heart rate goes back up because I got more what? Blood circulating. Okay, this is all about blood circulation. Okay, so that's variables. If I have an early, that means my heart rate goes down during the contraction, like during head compression. So let me go here, and let me see if I can get my whiteboard up. Hold on, let me share my screen, and let me go to whiteboard. Let me draw these, and you can see them better. Okay, so let me draw my contractions here. Okay, here we go. Nice contraction pattern. Okay, now if I'm having earlies, see this is the peak of the contraction. And so what happens is that he has a heart rate, maybe 120s, and I got squiggly lines, so I got variability. And this is called beat to beat. Okay, so now here I have a contraction. And so baby's tolerating everything really good. And now remember the station? My head is really getting low in mom's pelvis. So my head is getting squashed. So what happens is that my heart rate goes down during an early, okay, during the peak of the contraction. But once that's over, my heart rate goes back up. See, and I'm back. I'm doing good again. Yeah. And then mom has another contraction, and my head gets squished. And I go, oh, okay, all right, I'm coming down to see ya. And then I come back up because after the contraction, and then I go again. These are earlies. So the nair, which is the lowest portion of the deceleration, is right with the acme of the contraction. Okay. Again, the nair, NADIR, is with the peak of the contraction. This is head compression. So the head is coming down and getting really squished. So my heart rate is going to go down. But as soon as that contraction lets up, my heart rate goes back up, and I'm doing just fine, mom. And this is when I'm laboring a woman and I see early decelerations, I go, oh, this is good news. We got not only we got dilation, but we got the head coming down. And then she goes, ooh, I can feel it more. And sure enough, I go and check her, and she could be like a +2, +3 station. I go, this is good news. Okay, so this is okay. All right, this is okay. So let me get my any questions on early decelerations? Am I good? Head compression. Okay, let me go now to, let me erase this. Yeah. Okay. And let me go back up to my crayon. Okay. And all right, we're gonna draw. All right. So now I got my squiggy. Oh, I don't want that one. No. Hold on just a moment. Let me go back. Okay, let's see. Okay, I got my squig. Oh, here, that's good. Okay, so now I got my baby, and he's got some variability. She has a contraction. Okay. But, after that contraction is over, things should be okay. But my baby starts to have a deceleration after that contraction. So I'm going, it's after the contraction. So everything should be okay after the contraction. It should be plenty of blood perfusion, blood circulating, that his heart rate should not go down. And because this is caused, a late deceleration is caused by a uterine placenta insufficiency. That means that the uterus and the placenta, put it this way, they're not talking to each other, you know? And so they're not giving the blood supply that this baby needs. So he's trying to tell you, the nurse, I'm in trouble. I'm in trouble in here. So then you watch, and maybe the next contraction, he doesn't go down. Okay. So maybe during that time now, they got a little more blood supply. So his heart rate stayed stable. Then you get another contraction and his heart rate goes down after the contraction. Is down after the contraction. So after the contraction, again, it should be okay. There should be plenty of blood going through because the pressure is off. So he's in trouble. And babies cannot keep experiencing late decelerations. It cannot, because you have a problem with the uterus and the placenta. And sure enough, you have to get intervention. You can't. You have to get quick intervention. So write this down. Late decelerations are not reassuring. They're not. They're bad. The baby is compromised in some way. It's caused by uterine placenta insufficiency, and you have to get intervention. You have to get, so you can change maybe her position, mom's position to left side. Make sure you have an IV going. Give her some oxygen, 8 to 10 liters via tight face mask, and you get some help in there. So that mnemonic that I just said to you is LION, L-I-O-N. Everybody got that? So any questions on late decelerations? They're not good. They're not good because the problem is with the placenta and the uterus. Okay.
Hey,
Yeah, so I don't want late decelerations. Yeah. A question?
yes. I'm trying to go back to the beginning when you said late decelerations. You were saying that it's when the heart rate goes up or down.
Down.
And then, okay, heart
Down.
rate goes down, and then that's when it's you said
Yeah.
something about the placenta. You said it's
Yeah.
What did you say?
Okay. It's caused by the uterus. It's called uterine placenta insufficiency. So the placenta and the uterus, there's not the proper blood circulating. So the baby's heart rate goes down. So let me draw that out again. So here you have a heart rate, say of 120. You have a contraction. After the contraction's over with, when everything should be circulating okay, the heart rate goes down. See, it's after the contraction. The heart rate comes back up. He kind of maybe is okay again for a little bit. She has another contraction. It lets up. It's over. Heart rate goes down. Okay. And here, each time that heart rate goes down, the baby is not getting the oxygenation it needs. Eventually, babies can die if there's not intervention. So the heart rate goes down. Okay, so you can see that it occurs after the contraction. So here's your contraction, and baby's heart rate goes down. Then let me tell you, every contraction has about 50 millimeters of mercury pressure exerted. That's a lot on the babies. They feel that compression, okay? And the cord can get compressed. That's why sometimes you have variables. When this baby, after the contraction's up, there's no more pressure being exerted, okay? Everything should be good. There's blood circulating, okay? Then what this baby heart rate is down. That's not normal. That's not good. Never good. A late is never good. So I got to get this baby out because each time this baby has a late, late, baby's going to get more and more acidotic. And so babies can die because of a late deceleration. Does that make more sense now?
Uh-huh.
Okay. All right. And then I remember I talked about variables and cord compression. Let me draw you a variable to show you. Okay. So here, remember they vary. So here we're going around. I got a good heart rate of 120. I got a good heart rate. Then all of a sudden, okay, that's a variable. Okay, that looks like a V, right? And then he lets up and the heart rate goes back up. And then he grabs his cord again. Okay, and it comes back up. He lets up. Yeah, no. These are variables. These are caused by cord compression. And sometimes a variable can look like almost like a W. So it comes back up and then he grabs again and then it goes down and then it comes back up. Okay. That's also a variable. So a variable can be a V. It can also be a W shape. It can also be a U. Okay. Just remember, this is caused by compression of the cord. Okay. Now, accelerations are always good. So you have a heart rate of 120. And all of a sudden, you got a good increase. All right. And come back down. And then he goes back up. All right. Okay. This is reassuring. This is okay. This is good. So that's accelerations are A-okay. All right. Everybody good on this? Did anybody need any more explanation? So you'd be able to recognize it? All right.
Yes, ma'am, that was good. Thank you.
You're welcome. Okay. So let's move on. I think I have an example of late. So see, this is an actual strip, part of a strip. And you can see how the lates are occurring. And see here, he's got a little bit of variability. See the little squiggly lines? Yeah, but eventually you keep doing this. See how he lost variability here? You don't see those squiggly lines. That's going into absent variability. Okay, and that's not good. Just remember, you would want to have those good EKGs, make sure they're up and down, right? Those QRS intervals. Okay, so the same thing with a fetal monitor. Okay, how about a brain teaser? So a nurse caring for a patient in labor knows the fetal heart rates are in the 90s. Okay, is this normal?
No.
But after a uterine contraction, wow, after uterine contraction, this is how you're going to read these questions. So what do you think this describes? This describes a late deceleration, does it not? Yes.
Yeah.
Yeah. So which priority intervention should the nurse perform? Would you notify the provider, turn the patient to her side, increase the patient's Pitocin, and encourage the patient to take deep breaths?
2.
Get her up, right. Do something, right? And what's your next step going to be after you do that?
Maybe encourage them to take deep breaths or something.
No, I'm going to get that doctor in there. I gotta let the doctor know that I have late decelerations. Okay.
Okay.
I gotta do something because I can't just walk out of the room, right? So I'm going to turn it to the side and call the doctor. Okay. Late decelerations are never good. So when you read the question, you want to make sure that, so what's the question asking me? So the question, what's happening in the room? The fetal heart rate is in the 90s after a uterine contraction. Okay, that's a late deceleration. That's how those questions are going to be asked. Okay, we went over amniotic fluid already. Again, we know that it's clear. We know that it should not smell. That means infection. If it's brown, that's meconium fluid, right? And that we have to make sure this baby stays okay, because it can lead to compromise of the fetus. So we're going to monitor very closely this baby, okay? Because he's already had a little bit of distress that made him have his first stool before birth. All right, let's do another brain teaser. A woman in active labor experiences spontaneous rupture of membranes. Good question. Okay, so we're active. So which nursing actions are appropriate at this time? Okay, so so remember we talked about what you have to look for when she has spontaneous rupture membranes. So what do you say? Okay, go ahead, tell me.
The color, the amount.
Right. So the color is correct. How about monitoring the fetal heart rate?
Yeah, we have to do that too.
Yes, definitely. And what about, okay, and how about the time, right? And you
Yeah.
said the amount, correct. So if you chose A, B, C, and D, you are correct. All right. Now, you're probably saying, well, why why couldn't I take the lady to the bathroom? Okay, because she's in active labor. She just has spontaneous rupture. What else am I thinking about? Where's the baby's head, right? And where's the cord? Is if the baby was up high and all of a sudden she has spontaneous rupture membranes, I want to get into bed and want to monitor the fetal heart rate and I want to see where the baby's head is. Okay. What I'm assessing for a prolapse cord, correct?
Mhm.
Okay. Then we went over doula already. So we talked about that. We've gone over this quite a bit. This is the stages and phases of labor. So on this slide, I just show you that the first stage is the longest stage because it has the 3 phases. And then your second stage is expulsion of the fetus. That's our pushing stage. And we try not to go over 2 hours because then mommy gets too tired. Third stage is the delivery or expulsion of the placenta. And that can last from any 5 to 30 minutes. We want the placenta to come off the wall of the endometrium naturally. We do not want to pull on this placenta. Well, I'm going to tell you, I've had some providers where they say, oh, come on, the placenta is taking its time. So they try to pull, never pull. Because that snaps, that cord can snap, and then you got a big trouble. So never pull on the placenta, let it come off naturally. And when it comes off, it has to be intact, the placenta. And then the 4th stage is your recovery. Okay. Mrs. Pain management, we talked a little bit about epidural. So epidurals are really good. We go into the epidural space. We don't go into the spinal. We want to keep our patients very stable. So hold them tight so they do not move, because they do numb the area with some xylocaine. And then they use this long spinal needle to go into the epidural space, as is shown here. If she moves, it can slip and it can hit the spinal cord. And this has fluid in it. And what happens, she can get a terrible headache because of the nick. So, there's a leak. Now there's a leak. Now you put a little puncture hole in that spinal fluid. And so therefore now it leaks out and it gives her a terrible headache. It's awful headache, guys, awful. So we want to make sure that we have her in correct position. And a lot of times in the labor room, we'll get them, because this is the heart on the side. It's kind of hard for pregnant ladies to go and lay like this. So sometimes we sit them up on the side of the bed and have them lean over and make sure their shoulders are real relaxed. And I always say, like, get into a mad kitty cat position and we hold them tight, make sure they don't move. I'm always talking to my patients and we get it in. So we like to give it in the active phase of that first stage of labor. All right. And it's the reason why I say in the active phase is because that's when it's the hardest working stage. You know what I mean? Working phase. When you get into when you get into transition, you're like 8 to 10 centimeters. Labor is almost over, you know. And so if you give her an epidural too late, you know, she's already gone through the hardest part of labor. And so, and then she's got it. When you get into the second stage, I wanted to push. Well, if she's anesthetized from the waist down, can she push effectively?
Mhm.
Not really. No, because she can't, she'll have no feeling in her body, you know, in her lower portion. And so she pushes everywhere else but in her bottom. And you want them to be able to feel a little bit when they're pushing. So that's why I say the optimal time for an epidural is during the active phase. All right. The pudendal block, there's a really good picture in your textbook on the pudendal block, but what you're doing on a pudendal block is that you're just blocking the pudendal nerves, and they are on each side of the patient's pelvis. And we use that for vaginal delivery. It helps if, especially if they're like going natural and they're not, don't have an epidural. Pudendal block is nice, okay? In case they need to do like an episiotomy, that would be nice to have during that time. So when we give her a pudendal block, she's usually in the second stage of labor. She's been pushing, and then the doctor may say, "Well, I think I'm going to have to give an episiotomy, make a little wider opening," and so they'll do a pudendal block and anesthetize the nerves there. So it'll be much better for her. Okay. I'd like to go and talk a little bit about non-pharmacological childbirth. And what that is just not using drugs. Okay, that's what it is. So there's different types of preparation classes. You got your they're all good. The Bradley method, the Dick Reed method, and Lamaze, they're all good. They all want patients to breathe, to work with their bodies in order that they dilate and efface the cervix. Some techniques that we use, especially, you know, if they're in like the early or latent phase of the first stage of labor, we want to use some relaxation techniques. We can use skin stimulation, you know, touching. How about effleurage? Effleurage is really good. Mom puts her hands on her belly and she rubs her belly in like a circular motion. That's really good. Pelvic rocking is another good one. I talked about sacral pressure, especially in the beginning for OP position. Some heat, thermal stimulation. You know what's good too is hydrotherapy. Getting them in the whirlpool or the shower. I put my patients in the shower a lot of times, and they just relax and let that warm water go over their belly. Very, very effective. And then you have distraction and diversion. In the labor room, you have a big TV. You can have the TV on. You can have movies on. Anything to basically distract her. Okay. And then, of course, control breathing. All right. Let's talk before. I'm going to give a break in about 8 minutes. It'll be a short break, and then we'll come back. But let's talk before we go on break about vaginal birth after cesarean. That's called, the term is called VBAC, and you might have heard that. And these are special patients. I mean, basically, maybe they had their first cesarean because maybe the baby was breech. Okay, so now they're looking good for a second delivery. Maybe this baby is vertex, which is head first. So she says, I really would like to try to have a vaginal birth. Okay, all right. We have to be very careful because we cannot give them Pitocin like for labor induction. So you could never induce a VBAC. Write that down. Never induce a VBAC. And I can't augmentate her either. If she starts to go into spontaneous labor, and then she in like 5 hours dwindles down and stops contracting, I cannot augmentate her with Pitocin. That means I can't add, I can't help her. You know, it has to be spontaneous labor. That means her own body goes into labor. That means she produces her own oxytocin from her interior pituitary. So she has to go into her own labor. The reason why is because their uterine scar could rupture. And then you would have, you know, definitely now we have an obstetrical emergency. And the baby can be in jeopardy because don't forget, it could disrupt the placenta blood flow. It can also lead to a hemorrhage. So these women have to be well monitored. They have to go into spontaneous labor and deliver. So it does require a lot. And then especially I tell you, I've had patients who really wanted a VBAC. And so we waited for her to go into labor. And so she got to be 42 weeks and never went into, you know, wasn't going into labor. And she just kept waiting. And babies can't wait too long because everything gets old. The placenta can go to old. So we support them to a certain extent, but we also have to present the emergence of it. I mean, you know, we can't wait forever. Okay. So you have to really, I tell you, the hospital I worked at, we have a 10-page consent form for our VBACs. Okay. We go over everything with them because anything can happen. She can have a uterine scar that can rupture. One time I was first assisting on a C-section, and we had to rush this lady to the back. We opened her up real quick, and sure enough, we had to do a classical cut on the uterus. And sure enough, when we opened her up, the baby, we didn't have to do too much of a cut on the uterus because it was already open. Uterine scar gave way and opened it up, and the baby was floating inside mom's abdomen. Okay. Yeah. And so baby was still connected to the placenta through the cord, you know, so he was still getting oxygen, a little bit less, more diminished because your blood flow goes down. But we got the baby out, and they did resuscitation. I had the NICU team in there, and sure enough, and baby made it, and mom made it. Okay. Imagine the blood though that was circulating. It was tremendous blood. Okay. Yep. So it does happen. It does happen. That's why we have to be very careful. All right, let's see here. So let's go here. The nurse is caring for a woman who's delivering her first baby. So which of the following indicates the woman is in the third stage of labor?
Expulsion.
Right. You got it. See, that was quick, right? Now you got that down packed. Okay. The nurse is observing a patient for hemorrhage following a delivery. Which assessment finding indicates a maternal hemorrhage is occurring? This is a really good question.
D.
Okay, so select all that apply, right? So
D.
we definitely have tachycardia, correct?
A, B, D.
D.
Yes. So we got A. So write this down. If you didn't know this answer, you might see this again. So you got tachycardia. I have continuous flow of bright red blood, right?
Yeah.
I have hemorrhage. I saturated peripad ×3 within 1 hour. Hemorrhage. As a hemorrhage. Passing large blood clots. I'm hemorrhaging. That lady's hemorrhaging. Her fundus is probably boggy. And so, and then this other one, firm fundus at midline. No, that's normal. So no, that wouldn't be part. Her fundus would be what? Boggy, soft. Right. So write these down. So did you have them?
So A to D is correct, except E.
A to D. Tachycardia, continuous flow of bright red blood, a saturated peripad. Oh yeah, times 3 within 1 hour. Yeah, those peripads, you can hold up a lot of blood, guys. And then passing large blood clots. So that's never good. That's never good. Yeah. And the fundus would be soft. It would not be firm. It would be soft. So that this is a patient that's having a hemorrhage. All right, you got it?
Yes, please.
All right. All right, how about this one? The nurse assessing a client post-delivery knows that the uterus is now high, okay, and is displaced to the side. Which is the nurse's priority action?
C.
C.
Yes. C. I'm assessing for a bladder distension, correct? Because why? What is the question asking me? So I go back to the question. Okay, so she just had a baby. So I notice the uterus now is high, which is above the umbilicus, and over to the side. Oh, we need, her bladder is probably full. Okay, so now I go down, and the question says, which is the nurse's priority action? So now I go down, I see my choices, and there it is, bladder dissension. Always read those questions carefully. What's the question asking you? Okay, how about another one? Which nursing intervention should the nurse include for a client immediately after delivery to reduce bleeding and bruising of the perineum? Oh, this is easy. Come on.
D.
Huh?
Ice pack.
D.
And you say D like D is dog?
D as in dog.
You got it. Apply that ice. Okay. All right. So let's take a little break before we go into the rest. It's 4 o'clock, and you guys been great. So let's do a 10-minute break, and just enough to go to the bathroom, and then let's come back to slide 45. Okay. So don't come back in about 10 minutes because we want to get through everything, okay? Remember, this is a big review. All right. I'll be right back.
Okay.
Everybody go to use the restroom now. Okay. Clara, how you doing?
Good. How are you?
Good.
Okay. You didn't take a break?
So you understanding everything okay?
Yeah, I'm understanding very good.
Good, 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 good.
Yeah. Yep, I love the reviews. They're really good. Like it's making more sense now, you know.
Yeah, the more you listen to it and hear it,
Mhm.
it stays in. And that's
Yeah.
what you have to do. You have to understand it.
Mm-hmm.
Good. Good, good, good.
Oh my goodness.
I guess we still got a few more minutes, huh?
Yeah.
Okay.
Let me sign up so you can eat your lunch.
It's Chanel. Hello. It's Chanel.
Hey,
You look so pretty today.
thank you.
Oh, good. You must have been rested.
No.
Oh my goodness. Okay. All right.
Yeah, it's all right.
Some
How
more
are you
things.
feeling?
We got some more stuff to do.
Okay.
It's a lot when you do all these chapters, you know what I mean? It's a lot. Hang in
Yeah.
there. The Hesse
Okay.
reviews are long.
Oh gosh, I'm so over the Hesse.
That's over Hesse, yeah. Is it a Mr. or a Miss? I think it's a Mr.
Like,
Mr.
for real.
Hesse. Yeah. Well, I guess you're ready. Excuse me, I guess you're ready for boards. So we got to do it.
Yeah. Oh, he's absolutely. Yeah, he was
You,
fake.
I'm cousin. You chief phone.
Yes.
Hello.
What
You
you
chief
for?
phone, cousin.
He was fake.
Oh.
But he got a paper in his hand. For his contract.
That's not a contract. They just
Oh.
Mute your phone, cousin.
Oh.
All right. Welcome back, everybody, after our little short break. I'm going to go ahead and resume and share my screen so everybody can see a good screen. And we're going to go ahead and talk about a couple things. All right. So we already talked about augmentation of labor. That's when you give her Pitocin, which is a synthetic term. It's a synthetic, how am I going to put it? Synthetic use of, it's the same as oxytocin, but it's what man-made Pitocin is used to enhance the labor pattern. Just in case we have the Bishop score on your test, I just want to go over it so that you all know what we're looking at. So when we do an induction of labor, we use Pitocin. And what we're doing is we're starting her into labor. Okay. So normally in the optimal world, labor begins very natural. But sometimes it doesn't begin because she doesn't secrete the oxytocin. So we have to give her Pitocin. It's a synthetic version. That's what I was looking for. A synthetic version of oxytocin. So we use a Bishop score prior to the induction. Because what's my goal of an induction? Is to get the baby out.
Mm-hmm.
So I want to be successful. I don't want to induce somebody that's not inducible. So that means I can look at her cervix. I can see if she is, is she dilated? Is the effacement, at least 50, 60%? Is it soft? Where's the baby's head? Is he floating up above -5, or is he more engaged? Maybe he's coming down to a 0 station. I'm gonna look at maybe is cervix anterior or posterior. An anterior cervix is more inducible. So a minimal score of 6 is recommended by the American College of Obstetrician and Gynecology. That's the organization that sets the standards. So they say a 6. And I put on there's a great table in your book. It shows you the Bishop score and how we rate it. It does work, everybody. It does. And so we don't want to induce somebody who is like 0 dilated, as thick as anything. There's no effacement. The baby is floating. So you're not gonna be successful, not at all. So we want to have that Bishop score. The amnion fusion is just basically we're replacing the fluid that's maybe lost during a long labor. Maybe she had spontaneous rupture membrane. She had a big gush, so she lost a lot of fluids. And sometimes babies can have, remember I talked about those variables? And sometimes it's because there's a low amount of amniotic fluid. So I'm going to put back some fluids back into the uterus. And I can do that. Isn't that pretty neat? I can put in some sterile normal saline back into the uterus by using an IUPC, which is an intrauterine pressure catheter. So those are just some terms that you want to know. And also I would know what kind of patients can be induced and what cannot. Would you induce someone who is in a breech presentation?
No.
No. Good. Okay. So these are conditions that are contraindicated. These are conditions that you would not induce anybody. So remember, like placenta previa, you would not induce because the placenta is right over the cervical os, right? She would bleed to death if you labored her. Okay, so placenta previa, you never get Pitocin to. Umbilical cord prolapse, you don't induce because the cord is there. You can kill a baby if you induced her. Okay, you got to get the baby out immediately. Abnormal fetal presentation, like a breech. How about a transverse lie? You wouldn't induce that person. A high station of the fetus. We talked about that, whereas a -5, it's you probably wouldn't be successful. That's where that Bishop score comes in. Active herpes infection in the birth canal. No. We don't deliver active herpes. Those are cesareans. Abnormal size or structure of the mom's pelvis. If mom has a pretty big baby and she has a planetoid pelvis, you think you're going to be successful in your labor induction? No, you're not going to be. And previous classic cesarean section, you don't ever give Pitocin to a VBAC, remember? Okay. So those are people that we don't. These are some complications during labor and birth. So we already talked about induction and augmentation of labor. Everybody good on that?
Mm-hmm.
Okay. How about the Bishop score? Do you understand the Bishop score? You have a Bishop score of 6 or greater, you're in good shape to do induction the next day. An amniotomy. What's an amniotomy? That's where we're going to use an amniotic hook to rupture the membrane, right? Yeah, okay. An amniotomy. What is the nurse's role during an amniotomy?
Is it to monitor the fetal heart rate?
Yes, very good, Winnie. Mm-hmm. Absolutely. Monitor that fetal heart rate. We just talked about amnio infusion. That's what?
Replacing lost fluids.
Yes,
Mhm.
replacing lost fluids. Good, good, good. Aversion. We talked about where we have maybe a breach and mom wants to deliver vaginally. So we'll try to move that baby from a breech presentation to a cephalic or vertex presentation. So we'll do aversion under ultrasound guidance. Okay, episiotomy. Remember
Extension.
The split
ahead.
of the vagina?
Yeah, surgical cut is a nice, clean, straight cut. It can be midline or medial lateral. Good. Forceps. Oh, forceps delivery.
It's used to pull the baby out.
Yeah, they use. Yeah, those are stainless steel, right? They don't give. They're not soft. They're stainless steel, and you put them right against the baby's head, and that can cause like facial paralysis to the baby. A vacuum extractor. What is that?
They attach it to the
On the
baby's
head of the baby?
Yeah, they put this little thing on the top of the head. Let's see. What do you think, guys, if they put this on the baby's head? What do you think, what would you see around on his head? What would be
A
indicated?
hematoma.
Yeah, you can see a subtle hematoma right on the side of the head, right? And what's this one back here? It crosses the suture line.
Is it crowning?
No,
No,
it's
that's
called
I mean,
that's
cone.
How about well, yeah, it looks like it can come out of cone head. You're right. It's called capus. Remember that word? Let me say it to you. Capisuccedia. Remember? Yeah, you remember that now, right? It's right here. It's like on the crown of the head. It crosses the suture line. Crosses the suture line. Okay, and this could be from a forceps delivery, a vacuum extractor. Usually when you have a vacuum extractor, you see a good, I'll write this down, circular impression on the baby's head. Got it? You got it? Circular impression on the baby's head. On the side of the head, it's called a cephalhematoma. Now, these things do go down. So we had to reassure mom. So we know they go down. They don't look so pretty at birth, A hematoma is it's big, and mom goes, oh my gosh, mom's okay. You'll be all right. Baby's gonna be okay. The capisuccedia is right here, even though across the suture line, it's gonna be okay because that's fluid that accumulated underneath that scalp. Okay, you got it. Let's go back. Let's see where we up to. Yeah, okay. Let's see. Cesarean section. Okay. So there's two ways to have a baby. One's vaginal and one's cesarean. Cesarean, if they have a dysfunctional labor and they stop progressing, we have to get the baby out. It's the same type of care, except there's a couple extra things you have to worry about. You have to worry about the incision, and you have to monitor her drainage, right? Yeah. See if there's any drainage that's seeping through that dressing, right? And especially in the recovery room. I got a Foley catheter in, so I have to make sure that she's, her kidneys are working and everything's going good. My Foley catheter is correct and draining. You put it down to gravity so that it drains to gravity. Document the color of the urine, and so I'm going to check her lochia like you would do at a vaginal delivery. And then pain control has to be monitored after a cesarean because they do have incision pain. Now, the worst kind of patient I had, and I'll share with you because maybe this will make you remember it. My poor patient, we had her in the operating room. We tried to get this baby out from below. So what we did was the obstetrician cut an episiotomy. Okay. And then we struggled some more. We had a push and she couldn't deliver vaginally. So now we had to put her legs down, give her more her epidural, make a little higher block, come up, higher so we could do a cesarean. We ended up doing cesarean. That lady was in a lot of pain, and we had a Foley catheter in. We had to wash both the episiotomy site and the cesarean incision. Okay, that lady, she couldn't walk for a couple days. Even though we got her up to go walking, we had to get physical therapy to help her. It was a tough delivery, guys. It does happen. And here she had both an episiotomy and cesarean. So those kind of patients, you have to have strict pain relief, pain management with them. Okay. So we had an epidural, and they kept the epidural tubing in so that we could give her more, pain relief. Imagine that. That was a tough delivery. Let's go with problems with the power of labor and birth. That means the power is the contractions. So some contractions are irregular, some don't go into a good pattern. And so that would be a complications during labor and birth. Breech delivery, again, we get them out in cesarean, by cesarean. Another type of birth is called precipitous labor and birth. And that is a labor. Now write this down. That's a labor and delivery that all occurs within 3 hours of the whole process. So it's very quick. Now what happens with that is that they have hyper stimulation of the uterus, and that's called tachysystole. And with that kind of patient, they are prone to hemorrhage after delivery because the uterus has been contracting regular, like every minute for 3 hours, and did a good job. I mean, got the baby out, but now the uterus after birth is kind of slower. And so her fundus is boggy after delivery. And so it's hard to get that uterus to keep contracting after that delivery. Babies can have problems with a precipitous birth because they come down the birth canal way too quick, and they can have intracranial hemorrhage. Mom can have a vaginal hematoma, which is very painful. You might see that again. So a vaginal hematoma, it's very painful, and they need good pain medication for that one. Okay, let's see. The next one, preterm labor and birth, just like it sounds, is preterm. So it's before 37 weeks. And so those babies, we try to stop mom if we can. Now, if your patient, we hydrate them, get them hydrated, and see if we can get that uterus to stop contracting. But normally, if they get past 2 centimeters and like they're 90% effaced, it's hard to stop those pretermers. So what we do is we figure this lady is going to deliver, and we're going to try to get some what we call medication in her prior to delivery, and that's betamethasone. And that's a steroid that's given to mom, 2 doses, and it's given 24 hours as interval. And it increases, what it does, it increases the production of surfactant in the baby's lungs. And so you need surfactant in your lungs to able to go inhale and exhale. So if we can help this baby at birth to breathe, that's what we want to do. So we give mom betamethasone before delivery to our preemies, our preterm moms. And it really helps the baby to breathe at birth because she needs surfactant. All right. Prolapse cord. we discussed this a lot with the cord now. Maybe the head is up quite high. And so the cord now has plenty of room. And don't forget, the cord, we have a lot of amniotic fluid in there. So the cord is kind of just, swimming too. It's just kind of going back and forth. So all of a sudden now you have a ruptured membranes and the baby's head is up high. There's nothing to keep that cord from going down through gravity. Gravity pulls the cord, and so the cord can drop very easily. That's why the head of the baby, normally, if it's at, say, a -2 station, the head is quite big. So the head keeps that cord from prolapsing, from going down too low into the pelvis. Then you have uterine rupture. We talked about that, especially on our VBACs. So you have to be very, very careful. If you have somebody that has tachysystole, they have hyperstimulation of the uterus, they can get a uterine rupture. Okay, and then the last, I think it was in one of your chapters, it was about an amniotic fluid emboli, where your patient delivers, and we don't want this to happen, but it does happen, that amniotic fluid can get in mom's circulation, and it sends like a clot right up to her pulmonary artery, and she can die very quickly. So you don't want that to happen. But things like that can happen. That's why we call it a complications during labor. All right, let's see what we got here now. All right, so these are just your degrees of lacerations or episiotomy. Again, that perinatal tissue is very soft. And so you have first degree, which is just your superficial vaginal mucosa, okay? Or your just the skin, top layer. The second degree, it goes a little bit deeper. Now it goes into the vaginal mucosa. And it goes a little, as I said, it goes a little deeper tissues of the perineum. The third degree is the same as, say, the second degree, plus now it goes a little longer and it goes down into the anal sphincter. Now, the fourth degree extends through the anal sphincter into the rectal mucosa. Now, they can get fistulas from this. They can get very sick because they have a fourth degree episiotomy. So we don't want them to push, like after, they maybe they have to go to the bathroom, have a bowel movement, and they want to push out. A lot of times women with these kind of degrees of episiotomy, they don't even want to have a bowel. So you have to be very careful. So we make sure they have a high fiber diet. Write that down. Women who have, second degree, third degree, fourth degree episiotomy need a high fiber diet. They need to keep the bowels soft and flowing. All right. So you need to give them plenty of water, plenty of fluids, and a high fiber diet. And they're going to go home and you have to teach them what a high fiber diet is. And so you can use that, what the government on the My Plate, you can use that to use as an example of a high fiber diet. Now, in episiotomy, go back here. Don't forget ice packs. Ice packs, your best anti-inflammatory. So applying the ice pack to an episiotomy is always very good. Your patient will love it. Also, you have to teach them how to do pericare, so they don't get infected. And pericare is just putting a little bit of nice warm water in a bottle, and you should, every time she either urinates or has a bowel movement, she uses that to clean it off, and then pat dry from the front to the back, throw it away, and to keep everything nice and clean. Okay. We talked about forceps, and we talked about how it affects the fetal head. Okay, but it's a help when mom's pushing. So it's used at the end of the second stage, because second stage is when mom's pushing the baby, right? And so now we get to the point that, okay, the physician says, okay, I can help her a little bit by using a forceps And when she pushes, I will pull. And then we get the baby out. Now, sometimes too, you have to use the forceps even during a cesarean birth, only because sometimes babies are so stuck in there, okay? So I put a picture here of these forceps to make a point that they're pretty hard. They're stainless steel, they're pretty hard here, you can see. We talked about vacuum already, so I won't go into that in more detail, but you know, that's a vacuum. Here's a picture. And see, so you can see the mark on the baby's head would be in a circular motion. Okay. We talked about hematoma. Some of this are already I've talked about, so I won't take the time to go in again. But here's a brain teaser. So what would the nurse expect to assess an infant who was delivered with assistance of a vacuum extractor? Oh, there it is. Which one is it?
Secret hematoma.
D.
D, circular edema of the scalp. Wasn't that a good question? Okay. Next one. Which will the nurse expect to observe an infant delivered with a vacuum extractor? Oh my goodness, that's the same one, isn't it? Huh? Okay, if I had delivered with a forceps, what would be my forceps one? Facial paralysis? Yeah, exactly. Okay. Okay, so just know now we're going into the fourth stage of labor, which is what? Recovery, right? So you have here the nursing care. So when you take care of somebody after delivery, vital signs and any surgery, guys. Temperature. Make sure that her temperature is okay. It could rise to 100.4, but then it goes down. And that's why I always put a pitcher of water for my patient to drink, so I get the temperature to stay down. Pulse. This is a pretty important one. Now, normally, after delivery, she could have bradycardia. Okay. So if your patient has a high pulse after delivery, it does indicate something. It could indicate a hemorrhage or an infection. So just note that. So if you have a question, you want to read it very carefully. And the question would stay something like, patient just had a baby, and you notice on admission that her pulse is 110. So what do you think about? You think about tachycardia as one of your first signs of what? A hemorrhage, right? Going to shock, or it could be an infection. Okay. Check for edema. Okay. And then check the legs for a thrombus. What's the Holman sign? Holman sign, that's pretty important. So Holman sign, if your patient's complaining of pain in her calf, she could have some redness, some warmth to her leg, especially the calf area. That is a positive Holman sign, and that's an indication of a deep vein thrombus. So what are you going to do? Well, you're going to call the doctor, and after you assess her and tell him what's happening, and then he will write an order for a what? For a venous Doppler. You get a venous Doppler to rule out a blood clot. Because if you don't, then this blood clot that's in her leg will find its way to the pulmonary artery, and then your patient will have PE, pulmonary edema. Okay. Urinary. All right. So I have it in red here for a reason. So a full bladder can displace the uterus and lead to postpartum hemorrhage. So you check the uterus. Where should the uterus be after delivery? A uterus should
Two
be
finger breaths under the umbilicus.
at the umbilicus, right? At the umbilicus and midline, correct. So if you find that her uterus is above the umbilicus and deviated to the right or left, usually the right, then you're going to check her bladder. Okay, so you had to know the norm in order to know that above the umbilicus and over to the left or right is abnormal, correct? Yeah. So you have to make sure that you empty her bladder. And after you empty her bladder, guys, that uterus comes right back to midline and right back down to the level of the umbilicus. Okay, we've already talked about cesarean births and what the indication is. But another thing I didn't go over was placenta previa, which the placenta is laying right over the cervical os. So that would definitely be cesarean. And the placenta abruption. When you assess somebody for the placenta abruption, what does that uterus look like or feel like?
Hard.
Is hard, is board-like, right? Hard and board-like. That's your placenta abruption. That's an obstetrical emergency, and we got to get the baby out. Okay. All right. And we have cesareans for any time the fetus maybe late decelerations. You know, if the fetus is compromised in some way, baby's not going to tolerate labor, got to get the baby out. All right, good. All right. We talked about herpes. And we talked about, you know, abnormal dysfunctional labor. Okay, let's go on. Twins. Okay, twins are cute. They also are very challenging in the labor room because the uterus is so big and stretched out that it can cause the mom to have a dysfunctional labor. And you know, normally we go ahead and C-section for multi-fetal pregnancies. And sometimes if his mom is like gravid of 5, this is her 5th pregnancy, then she's had a proven pelvis before. That means she's had other deliveries that she's done very well on. We might deliver these breeches. But one usually is in cephalic or head first. And the second one, because it's usually how they're laying, you know. The other one's in a breech presentation. And so then we try to, once the first baby comes out, we call that twin A. Then we try to turn twin B into a vertex. You have to be always well prepared in case anything happens. You're prepared to do a cesarean. I would really know how to take care of somebody following cesarean delivery. Okay, it's a great all that apply question. So, and I said before, same as a normal, except we have an abdominal dressing we have to worry about. Okay, we have to assess that for drainage. A fundal assessment, we're going to check the fundus. We check it just like we do in a vaginal delivery. The lochia rubra. Okay. Now sometimes it could be less. It's because we do a good suctioning when we do a cesarean, and we get a lot of the blood, but they still have lochia rubra, so you'd be on alert for that. You have your catheter, your urinary catheter, your respiratory. Make sure that they're not laboring in their respiratory and that they're clean and they're able to move air in and out of their lungs. If they're a general anesthetic C-section, then we, remember what do you call those little gadgets? Make sure that they're breathing. And then prevention of thrombus. And of course, we talked about pain management. So we talked about all that. So let's see what question here. So which will the nurse anticipate assessing in a client following a cesarean delivery? Okay, now there you go, guys. So what would it be?
E.
Okay, so it's all that
A.
apply. Yeah. So we're gonna, Caleb. So we're gonna do the incisional dressing, right? Yes.
Yep.
We're gonna look at the lochia, right? We're gonna check her urinary output. We're gonna check vital signs, and we're gonna do fundal massage. So do all apply? All that apply.
Yes.
Yeah. Okay. Okay. All right. So we got a lady, she's postpartum, and we discussed Kegel exercises with her. So what is the purpose of a Kegel exercise?
A.
A, correct. You got that. Everybody got that?
Mm-hmm.
Okay, good. All right. We go over APGAR and APGAR scoring, and I have here APGAR. And this is not the greatest little slide. So let's see here. I have it better for you here. So you're looking at heart rate, respiratory effort, right? Muscle tone, reflex, and skin color. It's done at 1 minute and 5 minutes, correct? Okay. So why do we do an APGAR score? Anybody? We do APGAR scoring. It's not an intelligence score. It is a score that we use to know how much stimulation the baby needs at birth, right? If his heart rate is slow, we give him maybe a 1 because it's below what, 110 or 100. If his baby's heart rate is above 100, we give 2. If he's crying, great, we give him a 2, right? So we're looking at each area and we're going to give a score. Either if it's absent, it's going to be 0. If he has a low heart rate below 100, he gets a 1. If he's above 100, he'll get a 2. Each one of them, you get a score either 0, 1, or 2. Then you add them up. And so if you have a score of 8, is that good?
Yeah.
Yes.
Yes.
Yeah, an 8 is good. What would you do if during your when your baby comes out, if you have an APGAR 8, what would you do?
Oh, you wanna stimulate them, like rub their back or pat them a little bit, like a sting, not slapping?
Yeah, what I would do if I had a baby like that, I basically would make sure get him nice and dry. And remember, wipe them off. Remember, these babies are wet when they come out. They've been in amniotic fluid, right? So they're wet. So you want to dry them off real good. And when you dry them off, I'm not just, gently. I got a little rubbing a little bit. And when I do that, am I not stimulating that baby? I'm stimulating him. Okay. But I'm stimulating him, just gently. So what happens if my baby comes out, he has a score like from 4 to 7?
You retake the test in 5 minutes.
Yeah, but he also needs that stimulation, right? Rubbing the back. Okay. Because remember, 4 to 7, he's kind of sleepy. So 4 to 7, I need to give him some stimulation, such as rubbing the back. Maybe if mommy got a drug, say, just before delivery, what should I have on hand to give the baby? What drug should I have on hand at the radium warmer to give this baby? What reverses the effects of an opiate?
Narcan?
Narcan, right. So I'm going to have Narcan at delivery. So say I'm the labor room nurse, and I gave the patient, which I wouldn't do, but I gave the patient some Stadol, and she was like 9 centimeters. So shortly after that, she went to complete and started pushing. Okay. So she pushes, so the baby is out, but the baby is like sleepy because he just got pain medicine himself, right? He just got that from mom. So his heart rate may be low. His respiratory effort would be, he wouldn't be vigorously crying, so he'd get a 1. Muscle tone, he's kind of a little flaccid, so maybe get a 1. Reflex, maybe get a 1. So I already got what? 1, 2, 3, 4. And he's got skin color of 0. I said 1 minute. So I got an APGAR 4. So I've got to rigorously stimulate this baby and have some Narcan on hand to give this baby in order to reduce that respiratory depression, correct? And then I repeat my APGAR at 5 minutes. And by that time, I should see the heart rate go up. So he gets a 2. He's now crying, so he gets a 2. He's moving all around. So he's good. He gets a 2 for muscle tone. The reflexes are good. So now he got a 2. And skin color is he's still kind of, his tummy is pink, but his extremities are blue. So I got acrocyanosis, so I'm going to give him 1. So now I got 2, 4, 6, 8, 9, right? Yeah, 9. Am I doing good? Did our Narcan work?
Yes.
Yes. Okay. All right. So that's how you look at it when these babies are born as to why we do it. Dr. Virginia Apgar is a wonderful doctor that came up with this in order that nurses could do this assessment very quickly and do the interventions very quickly. Okay. We always want to be worried about thermal regulation on a newborn, because low temperature can lead to low glucose, and that can go into respiratory distress. So write that down. So hold on just a minute. Okay. Okay. So low temperature in a baby can lead to low blood sugar, and that can lead to respiratory distress. So I would worry about temperature. And so on a term newborn, you want the temperature to be like 96.8 to 97.7 skin, and then 97.7 to 98.6 axillary. It's very important to maintain the body temperature. You know, these delivery rooms can be cold, everybody. Okay. So I usually put the radiant warmer on in the delivery room and get the room a little bit warmer, because it can get so cold. Because I know here what can cause, and I don't want this to happen. I don't want the baby's blood sugar to go down. Okay. I'm going to just turn my phone here. Okay, hold on just a minute. Thank you. Okay, so I don't want my baby's blood sugar to go down, and then from there it goes into respiratory distress, because these babies can have respiratory distress so easily. Okay, and then also before this baby leaves that delivery room, operating room, you want that baby to be banded, have the bracelets on. So you have 2 bracelets on baby, one on around the wrist and one on his like right wrist and left ankle. And then also you have the security band on him. And you're making sure that he's banded before you leave the operating room. Okay, so here is a little brain teaser. So which security measure will the nurse take when bringing the client's newborn from the nursery to the mother's room?
D.
D, absolutely. You want to verify the infant ID matches the mom's ID. Absolutely. Now, there is like to a set of these bands, there's 4 to a set. So 2 goes on baby, 1 goes on mom, and the other one goes on the support person that she says she wants to have be banded. You have to have those on. You have to always check, because we don't want an infant abduction. Okay. Now, HESI, and for this exam, they always like you to know the normal vital signs for the infant. So I would know the normal respiratory rate, which is 30 to 60. When you know the norm, you can identify an abnormal. The heart rate is still the same. Remember, we saw fetal heart rate was 110 to 160. The infant is the same. So that's easy enough. And then you assess, your baby adequately, and then of course count for 1 full minute when you listen to the heart. Temperature I went over, so you can see that. Let me here. Let's do a little brain teaser. So which of the following interventions best promotes bonding following delivery?
B.
B, right, skin to skin contact. Okay, good. All right, let's go on here. So breastfeeding we have two hormones that are necessary for breastfeeding. One is prolactin, which causes the production of milk. And the other one's our famous oxytocin. It is in there, and that causes the milk to the let down oxytocin. Moms are always reluctant when they see the colostrum. That's the first milk. It's very thin and watery, and they go, "Oh, there's nothing to this. How is my baby going to grow?" That colostrum has protective antibodies. So write that down. Colostrum has protected antibodies. It is wonderful. And babies will get enough. And you want to give them these antibodies because a baby's only born with passive immunity from mom for only 1 month. So baby has to, build up his own immunity. Otherwise, the baby can get sick. That's why, you want to take these newborns out to the mall right after babies are born, because they can get sick very easily. So colostrum is very good. So, and how would I know my baby's getting enough fluids? Excuse me, I lost my voice. How would you know that the baby's getting enough fluids, everybody?
How much diaper changes you make a day?
Yeah, how many diaper changes should I have?
Is it 6 to 9 or
Oh, you're close. 6 to 8. That's good.
8?
That's
Okay.
good. That's good. Okay, let's go. Let's look at this question. So the nurse is discussing the different phases of milk production with the patient. So which phase of milk production will the nurse refer to when talking about the phase of milk production that contains protective antibodies?
B.
B, correct. You got it. All righty. Breastfeeding is wonderful. It promotes mother-infant bonding. It maintains the infant's temperature, okay, which is important when we talked about that. Sucking stimulates oxytocin to contract the mother's uterus. So that oxytocin that's good for the letdown that comes from the anterior pituitary. If mom is having a problem with having maybe too much bleeding, and so we did all our interventions, put the baby to breast after delivery, because that will stimulate more oxytocin, which will make her mother's uterus contract. Isn't that great? I always had my patients breastfeeding right after delivery. Honestly, it's the best thing. It makes sure that they don't hemorrhage. This goes over breastfeeding techniques. It just shows proper latching on. And let me go to here. I love this. This is right out of your textbook. Is latching on. Babies have to latch on properly. So they have the whole areola has to be in their mouth, because if they don't and they just hook on to mom's nipple, mom is going to have very sore, cracked nipples. Now, never a good thing, because that can lead to mastitis. And mastitis is an infection of the breast, and it's very uncomfortable. So that's why you have to teach them proper sucking. See? And this is really a problem with breastfeeding. And when you work on the mother-baby unit, and as LPN you have to make sure that this is going on, because mom gets a very sore breast and she gets very sick. And guess what she stops doing? She stops breastfeeding. She says, "Oh no, I'm not going to do that anymore." And she stops. Okay. And we teach mom how to break the suction. You just can't pull the baby off. Okay? Because when you do that, then she could have a sore breast, and that would be never good, sore nipples. So we just put our finger inside the baby's mouth to break the seal. And this just shows you the difference between a non-engorged breast. See all the little lobbles in here, all these glands. These are all normal, but look when it's engorged. Okay, it's because they're full and they're not going anywhere. Let me show you a good picture. This is a picture of mastitis. Now, do you think she want to breastfeed with that? No. You think once she gets cleared up, she says, that's it, I'm not doing anymore. They get very sick, everybody. They get high temperatures. You can see how red the breast is. Usually with this kind of looking breast, there's purulent drainage, have to be on antibiotics, and they have to be on pain medicine. Okay, we already went over this, evaluating the intake of an infant. So we went over this, and we have to remember 6 to 8 diapers a day. Let's do another brain teaser. Which of the following indicates successful breastfeeding is occurring?
A.
A, good. Okay, is that an easy question? That's an easy question. All right. Which nursing action best provides a postpartum client pain relief from breast engorgement?
C.
C, absolutely. Okay. All right, let me go down here. All right. The lactation nurse has provided breastfeeding education for a new mother. When discussed weaning, which statement by the mother indicates the need for further teaching? Now, weaning means that, you're going to decrease the amount of times you're breastfeeding. This occurs when maybe mom goes back to work, and she doesn't really want to pump her breast at work. So she's going to start weaning. It's a process because you just don't want to take a breastfeeding baby and just switch it over to bottom. Okay, that would not be nice. So on this one, this question says indicates the need for further teaching. That means it's not correct, correct?
Mm-hmm.
Right. So which one?
That would be D.
D.
It'll be B.
D.
D.
Abrupt weaning is easier because we can move quickly to a couple bottle. Yeah, that's right. Good. Okay. Which let me ask you, let me see if I have a question on that. Let me see. No. So which if you were weaning a baby off the breast, what part of the day would be the one I would breastfeed? Let me have. I would keep until the baby's almost ready to be totally weaned. Which one?
Nighttime.
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 Yes, thank you. You know what I was getting at, right? Okay, good. All right. So, this one here gradually. Yeah. Okay. We did that. All right. Oops. Well, let me see. Okay. We already went over this. Oh yeah, these are the slides that were mixed up. Okay, so we're good. We already did labor induction. We're good. Let's see, we did some of these. I already talked about amniotomy, so we can skip over that. We talked about that. All right, we talked about non-pharmacology. We got that. We're doing good, guys. We're almost done. We talked about episiotomy. Got some repeats here for you. Okay, here's your fiber diet for someone who has a 3rd-degree episiotomy laceration following a vaginal delivery. So this is what I use when I talk to my patients and they need to know what to add. Okay. We already talked about that. We did that brain teaser already. Okay, some of these are repeating, so I'm just going to skip over them. Let me see, we got some more. Okay, we talked about that already. This is a good question. What is the reason behind inserting a urinary Foley catheter before a cesarean? What do you think? Think now.
So it won't puncture the bladder.
Absolutely. You are absolutely right. Absolutely. You want to make sure that bladder is empty. We talked about psychic. Here's your typical labor room. These rooms are beautiful now in the hospital. Here's your birthing ball. Here's our bed. have a monitor. Usually the monitor's right in here, but you know, they wheel it in. Bedside table I talked about, and the nice couch for your family. It's really a nice setup. Yeah, here's a slide that I do have on precipitous birth. If you want to, you know, go over this again. Is a labor and birth all within 3 hours. And what you have to worry about is hyperstimulation of the uterus. And yeah, they can have uterine rupture. We talked about that, and lacerations and hematomas. Okay. And babies coming down too quick can get intracranial hemorrhage and nerve damage. So, you know, these babies that are born maybe on the side of the road, babies come really quick, you know, like in the, a lot of times TV shows have precipitous labor and birth also, you know. They have their problems. Okay, so here's a question. What type of complication could occur after precipitous delivery?
B.
Hemorrhage, right? 2. Yeah, hemorrhage. Okay, good. All right. When I test, if she comes into triage and she says I ruptured my membranes, you know, you go, okay, but you want to confirm it. And how you can confirm it is by using the litmus paper, which is your nitrocine paper test. And that will turn, it's yellow. And when you put it up by the in the vaginal vault, if she's ruptured, it will turn a dark blue. It's just a regular litmus paper. And so that's called the nitrocine paper test. Sometimes RNs, what we do is we'll put a sterile speculum, and we'll use a little sterile Q-tip, and we try to get a little bit of amniotic fluid up by the cervix, because sometimes they don't have a lot of fluid that you see, and so you don't get a good nitrocine test. So we're going to do a Ferning test. So we get a little bit of this amniotic fluid and we put it on a slide, and we take it to the microscope and we look at the slide, and what do you see? You see an actual like configuration of a fern, F-E-R-N. It's a Ferning test. And that tells you that the membranes are ruptured. So, you know, not everybody has a gross rupture, you know, a lot of fluid, not everybody. So you want to make sure before you send her home, say she's not ruptured. No. Got to make sure if you have an equivocal nitrocine paper test, you want to follow up properly. Okay. Now, another set of drugs is called tocolytic drug therapy, and that's used to stop labor. Now, the goal is to stop uterine contractions, and that can be the magnesium sulfate that we use for preeclampsia. Also works to relax the contractions, and it also works as a tocolytic therapy. So again, you want to, you know, keep her on the monitor. You want to make sure that she doesn't get too much magnesium sulfate. You want to test her reflexes to make sure she doesn't get too much. But that's it's a medication that can stop contractions. So here's a little question. So terbutaline is another tocolytic, okay, and it stops contractions. And so what's the side effect of a person who's on the breathine or terbutaline?
Heart rate?
Heart rate, good. It increases the heart rate. Good, okay. All righty. These are some contraindications that these are conditions that you don't give a tocolytic. Okay, so another one, preeclampsia. You know, if she's contracting and we're gonna and because of increased heart rate, we cannot give tocolytic to a preeclamptic patient because that would increase her blood pressure even more so. Placenta previa, we don't give too much tocolytics, is because, you know, it's time to get the baby out if she's bleeding a lot. Abruptio placentae, These are conditions that, again, obstetrical emergencies. And a chorioamnionitis is an infection. And so we don't give it. Now, fetal demise, we don't give it because we want the baby to come out and we want to get her delivered. Okay, so this is slide on prolonged pregnancy. I kind of thought she was kind of cute, this little picture, because this is getting to be longer than what, 41 weeks, right? So it's never, 40 weeks is a normal gestation period. Okay. 41 weeks, you start to get old. So it goes, now you're going to 41 weeks. Then you go into 42 weeks. Around that time, the placenta ages. Placenta is good for 40 weeks. That's what it's supposed to be for. And when you get toward prolonged 42 weeks, the placenta delivers less oxygen and nutrients to the baby. So babies can get in trouble. They can lose weight. They're getting old in there. Their skin starts to peel because the Vernix caseosa is being used up. They will continue to grow, and so there'll be big babies. So then the big baby then have to maybe end up being cesarean because the babies get too big. Meconium could be expelled, and because again, 40 weeks is term. So now the baby's system is starting to activate inside, and so we could have meconium. That could cause respiratory distress. So again, we want to get these babies out. And the main thing is with this placenta, it calcifies as it gets older. That means it's not as nourishing as it should be. And then these big babies can have a low glucose level. So at 41 weeks, 42 weeks, you're getting old. Okay, so here's some emergencies during childbirth. I think we talked about this already. Prolapsed cord is a obstetrical emergency. Uterine rupture. The uterus is open. You got a baby floating. It's definitely an emergency. And then, anytime, let me see, prolapse, we got amniotic fluid emboli. These are, again, emergencies during childbirth. You have to be really on top. Stopping preterm labor. We just went over that. I went over betamethasone with you. So what betamethasone does is steroid that increases fetal lung maturity. It increases the surfactant in the fetal's lungs. All right, let's see here. These are categories of postpartum complications. So now postpartum. So you got shock. So know your signs of shock. Hemorrhage. You have a thromboembolic disorder, which I could throw DVT. You can have infection, postpartum, puerperal infection. That means postpartum infections. Subinvolution of the uterus, where, remember, involution was where the uterus contracted back down to normal, right? 1 to 2 centimeters per day. Subinvolution means that the uterus is not contracting back down. So she's not going like she should, and so that's a postpartum complication because the uterus has to involute, to contract to go back down into the pelvis. Mood disorders. You have mood disorder. And this is a slide on shock. And these are different types of shock that you can have. Let me see here. So if I was to ask you the first sign of hypovolemic shock, what would you tell me? Tachycardia. So write that down, everybody. That tachycardia is my first sign of hypovolemic shock. Remember, after she delivers, it's normal that she has bradycardia. And so now, she's bleeding, her fundus is not firm, and she's getting she's getting tachycardia, her blood pressure's going down, she's got sweating, she is in shock. So you want to know that. Okay. And this is just a definition of how it happens in hypovolemic shock. It occurs when the volume of blood is depleted and cannot fill the circulatory system. Makes sense. Now, if you don't correct this very quickly, the woman can die. That's why you want to know those signs right away that something's happening. There's a lot of blood that's being lost at birth. Okay, there's a lot. That's why during pregnancy, she has a significant increase in her blood circulatory system. And so that at delivery, when she loses a lot of blood, the body can compensate for that blood loss. And that's what happens. But if she loses, because she's hemorrhaging, then her body will go into shock. And then that's when you see the tachycardia, the low blood pressure, increased respirations. And so you want to always do your nursing care. And so you want to do frequent vital signs. You want to monitor oxygenation levels, your assessment of the lochia, which is her drainage, right? We're always going to look for hematoma too. That perineal hematoma. If she had a difficult delivery, you want to look for that. Assessment of the fundus, firm with bleeding, could indicate a vaginal laceration. Let me tell you, when you have a vaginal laceration, it's a more trickle of blood. Put down vaginal laceration equals trickle of blood. And so you might have a firm fundus, but she's still bleeding. You're going, wait a minute. Now, I know that she's not supposed to have this bleeding if her fundus is really firm. She has some bleeding, but she's constantly bleeding. She's got this trickle, like a water faucet that has a drip, 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 drip. That's what a laceration is. It's like a drip, drip, drip. So you put on a clean pad, you come back maybe 30 minutes later, and she's got a good amount of bleeding, even when a fundus is firm. Then you got a laceration. It could be high up. It could have been maybe just the forceps. When they put those stainless steel blades in, they could have maybe made a little cut higher up in the vaginal area. So that's when you see a laceration. Okay, so I would know that. And then accurate measurement of your intake and output. You want to monitor IV fluids, and then you monitor for signs of anemia. And then, of course, always give emotional support to your patient. Okay, so you have early postpartum hemorrhage, could be from uterine atony. That means a uterus without tone, or some laceration or tears. We just talked about the reproductive tract, and hematomas in the reproductive. Yes, that's early postpartum hemorrhage. That happens what? It's a delivery. Now, this uterine atony, that's a uterus without tone, is quite serious. That's why you want to do the fundal massage. That's why you want to make sure her bladder is empty. You want to make sure that she doesn't have any placenta fragments. Okay, where if the doctors say put a little bit of pressure on that placenta to get it out, and maybe he tore the placenta off the endometrium, and there's still some fragments there, that can really make her uterus be without tone. A prolonged labor, the uterus has been contracting way too long, and so, or if you use something like tocolytic, say magnesium sulfate has a tendency to relax the uterus, because that's what it does, and that can make you have uterine atony, which is a uterus without tone. All right. Uterus without tone is boggy. We talked about that boggy uterus. The fundal height is not at the level of the umbilicus, it's now above the umbilicus. We talked about that. The lochia is increased and may have some large clots in it. And, we talked about this, where you get the patient up after delivery, and sometimes you don't know until she actually stands up how much true blood is being lost. And then, sometimes a collection of blood in the uterus can interfere with contractions and making this uterine atony even worse. So we have to have contractions at the afterwards, so it's called after pains. after birth pains. Okay, so let's see. Which medication will the nurse anticipate prescribed to control postpartum uterine atony?
Debridging.
Methogen. Okay, good. Methogen. Okay. All right, how about this one? The nurse assesses a postpartum client and knows uterine atony. Which action should the nurse perform first? I know you know that.
Fundal massage.
Fundal massage. Okay. I know you guys are getting tired. Hang in there. I think we're almost done and you're doing good. We talked about lacerations already. It's a trickle of blood, remember? Okay. And here it's usually brighter red blood than Loki and flows in a continuous trickle. So there it is. Okay, good. All right, hematomas we talked about already. Is unrelenting pain that's unrelieved by analgesics. They are in extreme pain. They have like a lot of pressure in the vulva, in the pelvis, and the rectum. You know, it could be maybe from birth trauma. You know, when those babies are so big, and you know we're trying to get the baby out. A lot of times we can cause more damage to the perineum because it's very, very tender tissue. It is. Okay. What is the nursing action that's appropriate in the care of a postpartum patient to prevent fundal displacement? All right, we know that one. Anybody? How about we ask the patient to void? Okay, very good. We talked about subinvolution, so we're good on that. It's just a slower than expected or failure of the uterus to return to its normal pre-pregnancy condition. Remember, involution is the normal process where the uterus descends 1 to 2 centimeters per day. Okay. All righty. I think we did pretty good here. How about we do another little brain teaser? Class of symptoms of a DVT include muscle pain, a positive Holman sign, and swelling of the affected limb. Is that true or false?
True.
True. You got it. Okay. Good. All right. Let's see. How about we do another brain teaser? Your patient is 5 weeks post-vaginal delivery. Okay, 5 weeks. During the doctor's visit, the patient states that she notices a foul-smelling drainage, pelvic discomfort, and she's been running a slight fever. The nurse relates these findings to which of the following. Remember, she's postpartum. She's 5 weeks postpartum, and she has a foul-smelling drainage. Her lochia is smelling, and she has pelvic discomfort. Which one of those tells you there's an infection in the uterus?
Is it
Is it
endometritis?
involution?
Yes, very good. Endometritis. Absolutely great. You see how I took that question and took it apart and how I read it and I reread it to myself? That's how you have to do too. Okay, so note that you do have some math on the exam. If it says, guys, round it to the nearest 10th, you round it to the nearest 10th. Watch the instructions. If it says round to the nearest 100th, you do the 100th, which is what, the 2. If you got to round it to the whole number, that means that it's a whole number. Just make sure that you are doing that. Okay. And the rest about on math, and you can see that for yourself. This is what we do. We got mommy, we got a beautiful baby, and a lovely daddy. So you're doing good, guys. You hung in there with me. I lost some people, and but it was well worth it. And let me see. I think we did. I'm just checking my notes. I think we did pretty good. And let's see, we did everything we were supposed to do. You should do very well just read the questions and go over the slides again, okay? All right, I'm going to end my recording.